I would propose at this point to take some questions for the speakers that we have already heard, and then we will continue with the cases. A couple of questions, one or two questions. The first one is, what would we do? That's from the auditors that are hearing us. What would you do in the case that you have a mixed cystic and solid lesion? So you have a cystic lesion of 6 centimeters with 2 centimeters solid nodule. Would you perform microwave on that one, or would you defer from doing such a treatment?
Okay. We also do ultrasound ablation for solid nodulars. In this presentation, we focused on cyst nodulars because in our practice we found intrahemorrhage most occurred in cyst nodulars, but rarely in solid nodulars. Thank you.
Thank you very much. Another question that we have for the parathyroid is, how can you tell that you have enough hydrodissection? How do you control how much hydrodissection do you do? And I can understand the 5% glucose for the RFA, but for the microwave, how does will hydrodissection help, or will you boil the water too with the hydrodissection? Thank you.
15的糖水做那个水隔离。
怎么去除水隔离，然后用什么成分
？Thank you. The isolation, isolation fluid, we use the normal saline, because the normal saline is very same the quality with 就是和人体和有那个体液一样，渗透压一样，这不好说。Sorry, because my English is very poor, so I in our department we use the normal saline, not other to have the isolation fluid, and I think the effect is very promising, and there is no side effect or other complication in the procedure. In fact, in our department. There are total more than 1,000 cases with steroid nodule, and about 1,300 is PHPT or acid PT. We use all the isolation fluid. We use normal saline. We think the normal saline is safe for in the procedure.
Alexis, may I comment on
please,
that?
Please. And before you comment, just to give you another question, so you can. These are for you. Do you perform track ablation when you're treating thyroid carcinomas, or would you just treat the lesion only? And again, please complete about the dissection. Thank you.
Okay, thank you. First of all, I appreciated the comment of Professor Ming. It's important to understand that when you use microwaves, you can perform hydrodissection injecting any kind of saline solution. If you use RFA, you should not inject saline solution. Otherwise, you have a great conduction and you have a boiling fluid. So when you use RFA, which in our Western countries is probably more used compared to microwaves for neck treatments, you must use dextrose or glucose, not at all saline solution, first of all. The question, Alexis, for me was if we perform track ablation at the end of the treatment, if I understand. We just perform a minimal amount of track ablation. We remove, when at the end of the treatment, we move back, we treat not more than 2-3 millimeters out of the nodule, and then we stop. You should not absolutely ablate with track ablation, muscles, perithyoidal tissue, and skin, because this will be very painful. So there is not a significant track ablation to be performed, just a minimal amount. When you reach the capsule of the thyroid, you should immediately stop and pull back without any heating.
他是说没有特殊的。
Okay, thank you very much. And we should proceed now. It's my time to present you the first case.
Dr. Alexis, can I ask a few questions?
Sure. Can you talk a little bit closer to the microphone?
Yeah. Can you hear me now?
Yes, now we can hear you better.
Yeah. I want to ask the question from Dr. Yu. Dr. Yu Ming, for parathyroid adenoma, the usual approach is trans-ischemic or is from the lateral side? Because most of the cases you have shown us is from trans-ischemic approach.
So the question is whether you use another approach than trans-ischemic, right? If I understand well.
Yes.
So Dr. Yu, do you use another approach or do you only go trans-ischemic?
Yeah, you go from trans-ischemic or you go from the lateral side of the neck, from the medial side or lateral side? Which approach is better for the parathyroid?
医师，我来翻译一下，可以吗？医师，您的那个，您静音了。
你说我吧，你说。
翻译一下。
就是刚刚 Dr. Ajit 问的是，就是关于那个parathyroidism， 就是做手术的时候是从那个峡部进针还是侧面
？OK，那你来帮我翻译，最好从峡部进针。有峡部进针的时候，有一个好处是，当它因为这个甲状腺结节经常位于气管摄管沟周围。 在甲旁抗，我知道，就甲旁抗在气管摄管沟周围，在从峡部进针的时候，可以进去以后，利用这个针的挑动，除了隔离，还可以使它这个针的挑动，可以使它更远离后反神经。你可以这么说。
Okay. So, Professor, you just told us that he prefers going through the trans-isthmus way so that he can. While he's doing the hydrodissection, he can also manage to lift the nodule away from the laryngeal nerve, so to protect it.
So I suppose the idea is that in order to have enough space to do the hydrodissection, you will go lateral with the needle for the hydrodissection because you need to pass under it, and then you will go transisthmic for the ablation because you will not have enough room for the two needles coming in. Are we in agreement with that?
Yes.
Gigi, any comments?
No, I totally agree. It's really extremely difficult to perform parathyroid ablations with a different approach. Transisthmic is almost mandatory for parathyroid and for posteriorly located thyroid nodules. Again, we must use a transisthmic approach always.
Okay.
My second question is to Dr. Solviti, Professor Solviti. Sir, in the cases of papillary carcinoma less than 1 centimeter, is there any chances of micrometastasis still in the normal looking lymph nodes?
This is a very good question. I should have had a much longer time to treat also that. The possibility to have micrometastasis in the nodes, not visible with ultrasound and not uptaking FDG on PET is not zero. It's reported between 1 and 10% in the cases of literature. But if we talk about papillary carcinomas, usually the development, the growth of these metastatic lesions is very slow, extremely slow. So the recommendation is, if you don't see any visible metastasis with ultrasound, if PET is absolutely negative, so no uptake, we are allowed to go on and perform the ablation. Of course, every patient must be followed strictly for at least 3 to 5 years with one ultrasound scan every 6 months and one PET every year, for example. We do every year to see if metastatic nodes develop. If they remain silent for more than 5 years, it is extremely uncommon that they develop.
Oh, yeah. Thank you, sir. Thank you. It's great.
Okay.
Any other questions from the panel? Okay.
Oh, yeah.
Please.
Yeah, I have a question to the Professor Subiadi. As you in presentation, the thermal ablation of PTC is very promising result, as well as metastasis lymph node. But in clinical, there are many there are some cases with PTC and a few metastases, but because they refuse to surgery, because they be afraid of the scar and the loss of the thyroid tissue, so they often ask me to have ablation for him to the thyroid nodule and the metastasis lymph node. But the first recommendation is surgery. So in this case, how do you suggest it?
No, it's a little different. The two topics are different. When we deal with nodal metastasis, especially if the patient has already undergone lymphadenectomy, in our experience, surgeons send patients to us for treatment because they don't like to reoperate the cervical spaces here. If the patient has not yet received lymphadenectomy, we have to discuss. For example, if we have only 1 or 2 small nodal metastases and the patient is female patient and young, usually they believe in patients. Patients ask for ablation, not for surgery, and they send the patient to us. In other cases, older people, male patients, we discuss, and sometimes they undergo surgery instead of ablation. But the number of patients sent for ablation of lymph nodes is increasing every year, and it will become more and more common. For thyroid nodules, it's different. In our experience here in Italy, people are more and more used to go to internet, to go to medical literature, and to check their situation. In many cases, they come to us as interventional oncologists saying, I have a nodule. My nodule, for example, is a benign nodule. I don't want to go to surgery. I ask for ablation. Okay, done. It's okay. It is in literature. I have a cancer. My cancer is 7 millimeter, 8 millimeter. I don't want to undergo surgery. We say, okay, we are for this kind of indication, we have to study you, to study your neck, to use ultrasound, to use PET, to use chest CT to see if your lungs are clean and so on. In this case, we can introduce ablation instead of surgery. For cancers larger than 1 cm, there are no guidelines, there are no suggestions of literature. So today we accept only particular cases in which, for example, the clinical situation of patients is so complicated, so rich of other diseases, of comorbidities, that ablation seems to be the best modality, better than surgery, but it is extremely difficult. Usually those cases are still surgical cases, in my opinion.
In fact, in our department, there are some more than 20 cases with thyroid PTC and metastasis lymph node. When they ask me to help microablation, I have undergone the microablation for her or for him. In the follow-up of 2 or 3 years, we found this very promising result, and there is no progression and no other lymph node. So after we summarize the data, we write an article, but the reviewer always ask me why you have microablation, why not let he or her to the surgery? So it's very
No, if I can interrupt you, Professor Kelekis knows very well. When we started lots of years ago, 20 years ago, 25 years ago, with ablation of the hepatocellular carcinomas, we had a tremendous fight with surgeons, especially with surgeons, because they used to say, this is our disease. You cannot invade our field. And it took years to have ablation introduced into the guidelines. In my personal opinion, in the field of thyroid nodules, benign or malignant, this way will be a little shorter. I think that in the next 5 to 10 years, the selection of ablation instead of surgery will be more and more common, and very soon we will have some suggestions or recommendations favoring ablation instead of surgery. I don't know if Alexis agrees with me.
It is like the first child. The first child has all the difficulties in life. The second one has the path already open.
Correct.
In order to save time, we have to move on with the next talk. So I'm sorry to interrupt this very interesting and passionate discussion, but we have to move forward, because we have a specific time frame to keep. So thank you all very much.